is improving how the PCP both evaluates the patient, their own assessment of the patient's risk, and how that's communicated to other people. So the thought was that we could risk stratify our patients into 3 groups: low, medium, and high, and that this is a risk stratification that's actually done by the PCP every 3 months. So I guess I would go here. And during the risk stratification, the PCP will review the regimen, see that it's still appropriate, make sure all the UTOXs have been done, that there have been no clinical changes. And then the patients would then be put into these groups of low, medium, and high. If you are a low-risk patient, you'd be someone who, for example, maybe frequently has their prescription last longer than 28 days, has a well-documented pathology for pain, has done wholehearted trials of other methods before going on to chronic opiates, has proven that they can tolerate their current dose, that there's been no concerns for diversion or pill loss or things like that, and are in a medically and socially stable environment, so have had no recent hospitalizations, questioning the amount they need, or complications. And if you're in the low-risk group, there are people who potentially only need to be seen every 3 months for appointments, and who can have their prescription sort of written ahead of time by a PCP or someone in their care group, which I'll get to next. If you are in the medium group, you're maybe someone who has a history of past addiction, so maybe you've been on methadone, successfully kicked an opiate habit, and now you have a chronic pain need. And even though you don't have any red flags, we just appreciate that you're at higher risk for that, and so you would maybe get a 2-month supply at any one time, or a Q2 month UTOXs, and that we would have a slightly closer eye on those people. And then Dr. Chen is also.
So I'm trying to get you right.
And also the UTOXs. Oh, okay.
Future UTOXs.
If you're a high-risk person, you are someone who has recently had some inconsistencies in the UTOX, whether that's seeing things like marijuana or cocaine, and if you've been deemed to continue your opiates versus stopping them, you would be in the high-risk group, so that would be monthly evaluations, most likely with a provider, not just with UTOXs, and be frequently reviewed in that respect. And then there would be other stipulations, like absolutely no early refills, no other sort of exceptions around next red flags. People who have had hospitalizations for being over-narked or things like that would also get a higher level of monitoring as well. And this would all be documented in the care coordination note. Other things to include in high risk, would be like suspicion for aberrant behavior, whether that's family members, misusing the medications on behalf of the patient, or patient diverting, or things like that. And so these are the 3 groups. To help meet the needs of these groups, because the PCP can't always be in clinic every month, we would have a care group. There it is, thank you. Teams of 3, and those would be 3 residents, who ideally one of them would be available in clinic every month to see these patients when they had to come in, for example, the high-risk group. And they would also be people who would be sort of doing the interval monitoring between the Q3 month PCP evaluations. So if there's been a clinical change, like a patient's now been hospitalized who's in the medium group for being over-narked, this is the person who would get that sort of a notification and coordinate with the PCP, or they themselves decide they have to be in the high-risk group and move the patient up. We also like the idea of having sort of a consistent pain clinic day to sort of address these different groups, but you guys sort of addressed that already. So that was sort of the basic idea of improving communication within our clinic and continuity for our patients.
Nice.